Hello and welcome. My name is Lisa Hatfield, your host for this Patient Empowerment Network program. In this important dialogue, we bridge the expert and patient voice to enable you and me to feel comfortable asking questions of our healthcare teams with more precision. The world is complicated, as is a cancer diagnosis, but understanding your CLL doesn't have to be. The goal is to create actionable pathways for getting the most out of CLL treatment and survivorship. Joining me today is Dr. Ryan Jacobs, a CLL expert from Levine Cancer Institute. Thank you very much for joining us today, Dr. Jacobs. We really appreciate you being here and your time and expertise.
Thanks for having me, Lisa.
Before we get started, please remember to download the program resource guide via the QR code. There is great information there that will be useful during this program and after. Okay, let's get started. So Dr. Jacobs, I'd like to talk about what's on the chronic lymphocytic leukemia radar. And rather than saying that entire phrase each time, I'm going to refer to it as CLL because I'm pretty sure I'll fumble that up. There's a lot going on in terms of novel therapies and new options. But before we jump into all of that, the toolbox that's expanding, can you introduce CLL and provide an explanation of what it is and what that means for a newly diagnosed patient?
Yeah, so chronic lymphocytic leukemia, or CLL, is the most common chronic lymphoma slash leukemia. It is really both most of the time. It presents with what we call lymphocytosis, meaning the white blood cell count, and specifically the lymphocyte count is high or elevated. To call it CLL, to make that formal cancer diagnosis, we can generally take a patient's blood sample and put it through a fancy machine that we call a flow cytometer that looks for characteristic markers on the outside of the cells. And if there's a bunch of those cells, we call that a monomorphic population. So a bunch of those cells that look the same, and they're B cells, that's the type of lymphocyte count they are, and they're over this threshold of 5,000, then that is the diagnosis right there. We don't need an invasive procedure. You generally do not need a bone marrow biopsy or a lymph node biopsy. There is, in about 15% of cases, the disease presents with just enlarged lymph nodes, and the white count is normal. We call that small lymphocytic lymphoma. It's considered an overlap with CLL, and I've had many patients that have started off with SLL and then eventually manifest elevated lymphocyte count later in their disease course. So it is considered an overlap. The treatment is the same for both of those disease entities. So that's the diagnosis of CLL and how it generally shows up initially. In a nutshell, it's a cancer of the aging population. Average age is 70. I have a lot of patients that ask me, why did I get CLL? And the answer is we don't know. It's that way with most cancers. Unfortunately, we don't know why one person gets a cancer and the other person doesn't. But it obviously has something to do with the aging effect on the DNA of the B lymphocyte because of how much more common it is as patients get older.
Thank you for that overview, Dr. Jacobs. We do have CLL patients who are watching this who are newly diagnosed. They may be in active treatment. They may be in remission. They may be managing their CLL just fine right now in their lives. So we're along the whole spectrum of CLL. So thank you for that overview. We know that therapies are evolving faster, or hopefully faster, than patients are relapsing, which is a good thing. So when they do relapse, chances are there will be a new option for this patient, but a CLL cure still remains elusive. So Dr. Jacobs, if you can speak to, we'll just jump right into some of the novel therapies and things that are being investigated with CLL treatments. If you can just speak to some of those newer therapies, the novel pathways and targets that are currently under investigation in CLL, we'd appreciate that.
Sure. We've come a long way in how we are managing this common cancer that's benefiting a lot of patients. And as mentioned, with this cancer being one that is more common in the older population, we do know that the population of the United States specifically is getting older. There's going to be more 70-year-olds. So these breakthroughs are helping a growing number of CLL patients. Before 2014, really outside of a clinical trial, the only way we could treat CLL is with combinations of chemotherapy and an immune therapy, like a monoclonal antibody called rituximab. That was kind of our first, what we would call targeted treatment outside of chemotherapy that we had. And it was like targeted treatments are well tolerated. It was an antibody that targets B cells specifically. So we were combining it with chemo. We would call that chemo immunotherapy. And it helped a lot of CLL patients, but for many, those with poor prognostic markers in particular, and those with relapse disease, chemotherapy was not very helpful, and it was quite toxic in many circumstances. So we've been fortunate that since 2014, we've had a lot of new treatment options, and they are targeted therapies. It's not like non-specific cytotoxic chemotherapy. These are treatments that have been developed with specific targets in mind that are unique to the B cell neoplasm, the B cell cancer, the CLL. And the first of these that really changed everything was a BTK inhibitor called ibrutinib that we got in 2014. Initially, we could only use it in the relapse setting, but eventually in 2016, we could start treating patients as a first line of therapy with ibrutinib. And then in 2019, we had a newer version of a BTK inhibitor. We call those second generation BTK inhibitors. That drug was acalabrutinib, and it eventually was shown in a head-to-head study to be just as effective as ibrutinib in a relapsed patient population, but it had less side effects than ibrutinib. So, and specifically atrial fibrillation, hypertension, cardiac toxicities overall were one that they really focused on in that study. So as a whole, when we were choosing BTK inhibitors, we were shifting away from ibrutinib, shifting to acalabrutinib, and then just as of not earlier this year, we had a third BTK inhibitor, zanubrutinib, that was approved. It's also considered a second generation BTK inhibitor like ibrutinib and acalabrutinib. It treats CLL in the same way in how it inhibits BTK, or Bruton's tyrosine kinase, that's overexpressed in CLL cells. But it also has a favorable toxicity profile when compared head-to-head to ibrutinib. And now we have two second generation options between acalabrutinib and zanubrutinib, and it's not really easy for us to know, between those two, which is quote unquote better. We are trying to, when we decide to treat with a BTK inhibitor, we're usually choosing between those two at this point, and we're trying to personalize the decision for the patient. And there's some different factors that can get involved in that complicated decision. Luckily, we are not limited to BTK as a target. I mentioned earlier, we have monoclonal antibody. Rituximab was the one I mentioned, but a newer version of rituximab, a more potent version, obinutuzumab, is one that we have available, along with a BCL2 inhibitor, venetoclax, that is now, as of 2018, approved in the frontline CLL setting, also approved in the relapse setting, of course, since 2016. And we use venetoclax with a monoclonal antibody like obinutuzumab, and together they are a very potent combination that cause pretty rapid cancer cell death, as opposed to the BTK inhibitors that more put the cancer to sleep and require daily dosing indefinitely for as long as the drugs work. And remarkably, the data on BTK inhibitors tells us it should work for many, many years. They've been following some of the patients that got treatment in the first line setting, and 8 years out, there's still more than 50% of the patients are free of progression, so they can't even quote an average response time yet with 8 years of follow-up on the early ibrutinib patients. The difference with venetoclax combined with a monoclonal antibody like obinutuzumab is because it causes a more rapid cell death. You can give it on a time-defined schedule. So we tend to give it for 1 year in the first line setting and 2 years in the relapse setting, and the antibody portion is just given for the first 6 months. The BTK inhibitors and venetoclax are oral treatments, so that's a big win for patients to avoid the infusion center for those treatments. But the IV antibody treatments, will still require some trips to the infusion center if you're doing that combination with venetoclax. For most patients, those two targets are what we're choosing between, and we try to personalize the decision to the patient. And again, that's a very complicated discussion on what is quote unquote best. And we use things like the prognostic workup, medical problems that the patients already have, medicines that patients are on to help make the best treatment decision for our CLL patients. But those in terms of how well that treats the CLL, both of those are considered equivalent options for the large majority of CLL patients. We've got some things on the horizon, but in general, those are our two targets that we have at this point. There is, for relapse patients, PI3 kinase inhibitors that are still FDA approved at this time that aren't quite as effective and more toxic. So we sometimes think about using one of those targeted therapies if a patient has already progressed on a BTK inhibitor and venetoclax. In the future, we are looking towards combining BTK and BCL2 inhibitor, like for example, there's been studies already done that I've put many patients on with ibrutinib venetoclax, and I believe there's a question about that later. There's also an ongoing study that I have open at my institution that's looking at acalabrutinib and venetoclax. So taking these two pills together in a time-defined manner, so you don't have to take the BTK inhibitor indefinitely. And then there's some therapies that have already been approved in other lymphomas, and we wonder if they're going to have a role in CLL eventually. So we now have bispecific antibodies. So that's taking a drug like rituximab or obinutuzumab and adding a T-cell engager to it. So it has two targets, or it's bispecific, and we have that drug mosunetuzumab available in follicular lymphoma, and there's several others in development, and we'll see how their role comes into play in CLL, as well as CAR T-cell therapy, where we take a patient's T-cells and genetically engineer them to attack the cancer. That's now an approved therapy for many different kinds of lymphomas and multiple myeloma as well. So we wonder if that's going to have a role in CLL. But I think for the foreseeable future, it's going to be looking first at BTK and then BCL2 inhibition, or vice versa. And we don't really know which is better to go first. We think they can both be sequenced one after the other. And then maybe we'll have some of these other breakthroughs coming in and helping for after patients need something beyond those therapies. And there's probably going to be a lot of patients that never need anything beyond those those initial couple of targets because they do so well. I think in the most immediate future, the approval that is going to give us a new great option is going to be for an alternative site BTK inhibitor, it's also called a non-covalent BTK inhibitor, and there's this drug called pirtobrutinib. It has been approved in mantle cell lymphoma, and likely will get approved in CLL this year. And that drug specifically is a BTK inhibitor that still works even in patients that have, say, progressed on ibrutinib or acalabrutinib or zanubrutinib. So that will be a new target available for CLL patients, and probably pretty quickly become, one of the go-to drugs that we used for relapsed CLL patients that have already been treated with a BTK, with a traditional BTK inhibitor. So growing number of options, and it's really great for our CLL patients.
Thank you for that overview again, Dr. Jacobs. It does sound like there are a lot of new therapies coming out, especially for relapsed patients. Super exciting for them. And this is actually a great time to jump right into questions. We have many questions from patients that different patients have submitted. But first, I want to remind everybody that this program is not a substitute for medical care. Please consult with your medical team for advice on your own condition or disease. And Dr. Jacobs, I was taking notes as you were talking because you had spoken a little bit about a combination of the BTK inhibitor and BCL2 inhibitor with venetoclax. And I did a little research last night before I talked with you, and it sounds like that is something that the Captivate trial is investigating. So that's exciting. And a patient asked about that, what that trial is. And it's music to my ears as a cancer patient to hear something like fixed duration. It's also investigating a fixed duration. So patients can have maybe a bit of a medication vacation. So can you speak to that trial a little bit and explain what it is a little bit and how that might benefit patients with CLL?
Yeah, so one of the best elements of treating with venetoclax is that it produces a deep level of remission in many patients. In fact, when given with the monoclonal antibody obinutuzumab to CLL patients receiving that treatment as a first line of therapy for their CLL, about 3/4 of CLL patients will get to so deep of a remission that we call them minimal residual disease negative. And that's a blood test or a bone marrow test, but more easily done as a blood test, where we can look to a sensitivity of 1 in 10,000 white cells and determine if there's any CLL in those 10,000 cells. And if we can actually go deeper than that, but we call patients negative if they're less than 1 in 10,000. And so 75% of patients will get to that depth of remission just with obinutuzumab for 6 months, along with venetoclax for a year. So when researchers saw that, they recognized that we could probably stop treatment, in those patients getting venetoclax, because venetoclax yields these deep responses. And then the next kind of thought was, well, could we give a BTK inhibitor with venetoclax, but also over a defined treatment timeline, and maybe get some of the remarkable benefits of treating with a BTK inhibitor, but not get stuck being on therapy for years and years. So the Captivate study was the first really to, in a large phase 2 manner, look at that combination in a younger patient population. It was for patients 70 and younger, and it wasn't in a high risk or anything. It was all comers, but they did have to be 70 and younger and getting treatment as a first line therapy. So the combination was very effective. As of the last American Society of Hematology meeting in December, like 4 years of data was reported, and a large percentage of patients were still free of progression, over 80% still free of progression. And that's 3 years off therapy at that point. It was well tolerated, not many patients had to come off due to toxicity. It was in fact less than 10%. Had really significant toxicities requiring, discontinuation. So it was a well-tolerated, effective treatment. And I do have one of those studies open at my institution, the acalabrutinib venetoclax combination. It's called the MAGIC trial, and it is a large phase 3 study that, if it's successful, I think would lead to the approval of giving those two drugs together. But then the extra credit question is, who should get the combination and who should get the drugs separately, and we don't have an answer for that right now, and that's a long topic of debate among CLL specialists.
Great. Well, thank you. So for that trial you spoke of that you're conducting right now, is it only relapsed patients who are eligible for that, or is that for frontline therapy?
This is the first line therapy study.
Excellent.
Yeah, the MAGIC study is. Mm-hmm.
Oh, good. That's promising for patients too.
And it has a really good comparator arm, so that won't be a problem. The standard arm on that study is venetoclax plus obinutuzumab, so it's comparing against one of our best treatments, and so we really will get the answer of does it look better to use the BTK with the BCL2, or is it not really that much better than just giving venetoclax with obinutuzumab? And then the one obvious element that I didn't mention that would be nice for most patients, in addition to being efficacious and well tolerated, is if you could get an all oral combination. Of course, venetoclax with obinutuzumab, you're still getting quite a few infusions with the obinutuzumab over the first 6 months. So that's a lot of time in the infusion center that you could avoid with just the combination of two oral targeted agents. So that would be a breakthrough for patients too, I think.
Mm-hmm. Well, and you commented also on something that's really important for patients to know, and that is that if you go into a clinical trial, you won't be given nothing for cancer clinical trials. You're going to be given the standard of care or whatever it's being compared to. So for patients who are considering that.
Yeah,
okay,
for phase
yes.
3. Yeah. If you go on an earlier phase trial, you know exactly what you're getting. There's usually not any randomization for earlier phase studies. You just get the intended treatment.
Okay, great. Well, thank you so much for explaining that. So we have some more pretty specific questions. And we have a patient who wrote in and asked, what is the difference between IGHV mutated and IGHV unmutated CLL? And can you talk about treatment considerations for those?
Yeah, so that's part of a bigger discussion around the prognostic workup of CLL, and not all CLL is the same. And we've done a really good job of figuring out tests to separate out the CLL patients that tend to behave more aggressively and respond to certain kind of therapies versus those that are more what we call indolent or slow growing and respond to other kinds of therapies. I do want to say, I haven't mentioned it yet, we still don't treat CLL if it's not causing any problems. And about half of patients get diagnosed as sort of an accident, and they get a blood test for something else and their white count is elevated, and that leads to a diagnosis, but they feel fine. We still leave those patients alone, even with these good treatment options we have. We recognize that there are a select percentage of CLL patients that don't ever need treatment, and so we don't just want to start treatment in everybody. But I do still like to check this prognostic workup, even if I'm not going to start treatment. But I make sure and ask the patient if that's what in line with their with what they want. But certainly, if you're going to start treatment, you're required by guidelines to check a prognostic workup, and I would, really encourage the CLL patients tuning in to ask their oncologist, what is my prognostic workup if they're going to start treatment, because the oncologists, unfortunately, that have to deal with lots of other cancers maybe don't always know the right tests to send. I'm very spoiled in that I get to just treat lymphoma, and specifically focus a lot of my research in CLL and get to stay up with all this. I don't know how a general oncologist keeps up with everything, honestly. But the big three tests are going to be the FISH analysis, fluorescence in situ hybridization, and then IGHV mutational analysis, and then also a TP53 mutation analysis. And I don't really have time to go through all of those, but IGHV is the question I get a lot. You know, what is that? It's one of these rare findings where it's actually normal to have a mutation at the IGHV loci. So IGHV stands for immune globulin heavy chain variable region, and it is usually mutated in B lymphocytes because it's part of the process of a mature lymphocyte that is able to make a lot of different kinds of antibodies. And it undergoes somatic hypermutation is what it's called as the B cell matures. Generally in oncology, the more mature a cancer is, the less aggressive it behaves, and usually the easier it is to manage, and that is the case with CLL. So think of an unmutated IGHV CLL cancer as a more primitive or a more immature cancer clone, and as such, it is harder to treat. And you know, about half of patients will be found to be unmutated at the IGHV, and historically, you know, all we had was chemo, and we knew these patients weren't going to respond for near as long as the IGHV mutated patients were to chemo. What's nice is with our targeted treatments, particularly, you know, the long-term data with the BTK inhibitors, it doesn't look like it matters whether you're mutated or you're unmutated. So that's one of the really great things with our new treatments for CLL is it has the people that have benefited the most are the ones that were doing the worst. So that's great. It's not just the patients that were already doing well that are doing even better.
So I just want to take a step back. I'm kind of looking at this through the lens of a newly diagnosed CLL patient. You had mentioned that sometimes you don't treat every CLL patient. So is there something, if you find a patient who does not need treatment, is there something that you tell the patients as far as regular monitoring? Will you monitor them to see if it progresses to the point where it requires treatment?
Yeah, and we're fortunate that this is a blood cancer that most of the time we can follow with a simple blood count and follow the white count, follow the health of the bone marrow by looking at things like anemia, low red cell count, or a low platelet count that we call thrombocytopenia. So that's the easiest thing to follow. But I'm also talking with my patients and examining my patients. I want to know if their lymph nodes are causing them a lot of pain, because we should treat that. There's no reason they should live in pain. I want to know if they're waking up drenched in sweat all the time, if their quality of life has been really affected by that, or a dramatic amount of fatigue that we can't explain by some other cause. And I also, of course, examine the nodes myself and make sure that there's no alarming findings there. So that's really what's involved with checking on a CLL patient that's on active surveillance. That's what we call it. And there's a list of criteria that the oncologist should know in terms of deeming, you know, who needs treatment and who doesn't. And so we're all kind of following the same rules, so to speak, in terms of who gets treated for CLL.
Okay, thank you. So we have a patient who asked a series of questions here, and I think you spoke pretty well to the role of the BTK inhibitors in treating CLL. I'm going to kind of clump these together. So I guess 3 questions. What treatments do you think are the most beneficial for patients whose CLL has relapsed? Mm-hmm. What are the poor prognostic indicators for CLL? And kind of along those same lines, what are the high-risk genetic markers for CLL?
Yeah. It's a little more complicated discussion in the first line setting. because both are options. At this point in time, we haven't been, at least those that are, I would say, staying up to date on the CLL data, we have not been using chemotherapy for a long time. So most of the relapsed patients will have seen either one of the BTK inhibitors or venetoclax. And so what we do in the second line setting is just use the other option that they haven't seen. So the data tells us, when you look at what treatments are being prescribed, most patients are going on BTK inhibitors, and they have been around longer than venetoclax in general. So for a lot of patients, that relapsed treatment is going to be venetoclax, because that has the best data in terms of treating patients that have progressed on a BTK inhibitor like ibrutinib or acalabrutinib or zanubrutinib. In the near future, we'll have pirtobrutinib, and so maybe some will get that drug before venetoclax, and that's probably okay. And so we'll have that additional option. The complicated patients, and I've alluded to this, are what do we do after BTK and BCL2? What are we left with? I mentioned PI3 kinase. That's not a great option. There's still stem cell transplant out there for young patients that are running out of options. Clinical trial is really what I would like to emphasize there. If you're a patient that can get to a high volume referral cancer center with a CLL specialist, I would do that if you have seen BTK and seen a BTK inhibitor and venetoclax and are looking for other options.
Great, thank you. So the next question is actually a really good question. I think we can broaden it a little bit, but the question is, how can I ask my doctor to make sure I am being tested for serum markers? And more broadly, I think a lot of patients are a little bit nervous about asking questions of their doctor because they don't want to feel like they're questioning their expertise or doubting them. So how in general can we ask our doctor questions if we hear something, or how do we approach our doctor with those type of questions?
Yeah, so I mentioned, asking your doctor, what's my prognostic markers, I think is probably the easiest way to get that information. And your doctor, should be checking those. The question comes up like, what are the quote unquote high risk markers? We talked about mutated versus unmutated. Thankfully, our novel treatments, that doesn't seem to matter. Same goes with, there's on FISH, there used to be, if you found 3 copies of chromosome 12, but that's called trisomy 12. That doesn't seem to matter with our newer treatments. A deletion at chromosome 11, again, used to not do as well with chemo. Novel therapies doesn't seem to matter. The one that is still potentially affecting outcomes, even with our novel treatments, are chromosome 17 aberrations, which thankfully are rare in the initial diagnostic setting. That or a TP53, a deletion at 17p or TP53 mutation probably is only going to be around 10% of patients or so. And in the relapse setting, though, that number goes up because of, the more aggressive cancers emerge. We call that clonal evolution. So maybe in the 20-ish% range. These patients, we tend to prioritize indefinite therapies first, because it seems like these patients do better if you keep treatment going, as opposed to interrupted therapies like venetoclax. And so we tend to treat those patients with a drug like acalabrutinib or zanubrutinib first, and then think about venetoclax later for those patients.
Okay. And just to clarify for patients too, I know that a lot of cancers, there are discussions about the deletion 17p, and then also the TP53 gene. So if I understand correctly, the TP53 gene is housed on chromosome number 17. So if that is missing, then that patient may be missing that gene that is considered a tumor suppressor gene, which we want. Is that correct? Just
right. So it's either missing, which is what we see on FISH with a deletion, or it can be mutated, and that's the next gen sequencing, and often it will be both. And in those patients, we think with indefinite there's some really good data, that was just released with zanubrutinib when they looked at 17p deleted patients. There's some long-term follow-up with ibrutinib treated 17p deleted patients. So, with chemo, these patients would only get about a year or so, but we're getting maybe even close to normal outcomes with long-term BTK. But we do know if you just give them a year of venetoclax and obinutuzumab for 6 months and then stop, they do relapse quicker than the other patients. So they relapse after about 4 years, as opposed to with 5 years of follow-up with that first-line venetoclax approach, only there's 62% of patients are still free of progression.
Oh, wow. Okay. Thanks for explaining that too. I know that chromosome 17 and the TP53 gene, that's talked about in a lot of different cancers and often comes up. How are those connected? So thanks for just describing that a bit. So this patient is asking, for patients who may be eligible for BTK inhibitors, are there specific comorbidities that might contribute to adverse side effects?
Yeah, so we screen all BTK inhibitors have some cardiac toxicity. They have been shown with the second generation BTK inhibitors to have less cardiac toxicity than ibrutinib, specifically atrial fibrillation. So if you have atrial fibrillation, maybe that's a reason why you might go on venetoclax first, as opposed to a BTK inhibitor, but it's not a contraindication to getting a BTK inhibitor if the atrial fibrillation is under good control. Other cardiac risk factors would include, difficult to control hypertension at baseline or heart failure. These are all things that might make us think twice about using a BTK inhibitor as our first therapy, because venetoclax has no cardiac toxicities. The other thing to consider is BTK inhibitors all, to a degree, have, and I describe it to patients like an aspirin-like effect on the platelets. They do interfere with platelet binding, so universally patients will note to varying levels, some easier bruising. And if patients are on, because of, say, they've had a heart attack in the past and they're on aspirin at baseline, or what would even be more concerning if they were on, like a drug like Plavix because they've had a stent placed, that would be something that would really concern me, and would definitely push me more towards venetoclax, that again doesn't have those antiplatelet interactions. Also, patients are on blood thinners because of a history of blood clot or atrial fibrillation. There is the potential increased risk for bleeding and bruising there as well. None of these are absolute contraindications. They're just all what goes into the blender, if you will, of putting lots of information in and coming up with a best treatment decision that's personalized for the CLL patient. We're blessed to have multiple options, but it does make it more of a challenge to find the quote unquote best option.
Yeah. Thank you for that. We have several questions from a couple of patients regarding side effects. So the question, how long will my side effects of my CLL treatment last, and what can be done to reduce those? And specifically, a patient is asking if there's a connection with CLL and gastrointestinal issues.
So all of the treatments, including venetoclax, the BTK inhibitors, will have diarrhea listed as a possible side effect. It's usually low grade, but generally I have found the gastrointestinal toxicities abate some over time. So if they are present earlier, if you're able to stick with therapy, they do tend to get better. For the once daily meds, I encourage those patients to try to take the drug in the evening. The GI tract tends to be less active later in the day, so and you can sleep off some of the potential gastrointestinal issues. So I've had success there. Sometimes we have to lower the dose to just find the best dose to help mitigate some of these. There's the antidiarrheals that can help if you need Imodium. I had a patient I saw earlier this week that Imodium didn't really work, but good old Pepto-Bismol did the trick from time to time. So certainly though, if the gastrointestinal issues are significantly affecting quality of life, we need to come up with a new plan, and whether that's reducing the dose or changing to a different option. Like specifically, what's nice about the BTK inhibitors is they all have data that show if you're having problems with one, you can switch to the other and likely not have the same problem occur. So that's nice.
Have you ever seen any uncharacteristic side effects several times in your practice? Anything really unique? I'm just curious about that.
Yeah, I mean, there's always the the patients that can have like a more severe form of maybe a less of a more common side effect, like the we were talking about diarrhea. I've had a patient that that actually had difficult with venetoclax, had difficulties with stool incontinence. So that was kind of a severe form of that. It wasn't so much diarrhea, that was the problem, but we were able to ultimately mitigate that with a dose reduction. I would say the way, as particularly if it's an unusual side effect, the best thing to do is to take a break. If it's a serious side effect that needs to be addressed, and it's affecting quality of life or causing problems, take a break from the treatment. If you take a week off these treatments, particularly venetoclax, taking breaks doesn't matter. We like not to take long breaks with the BTK inhibitors, but if you take a week off, these drugs don't have very long half-lives. So if the issue is not getting any better and you've been off of treatment for a week, it's unlikely that issue is coming from the treatment. So that's a way I try to sort through particularly if they're unusual side effects sometimes. And certainly if we deem that the issue is connected to the treatment, I'll usually try lowering the dose before just giving up.
Okay, thank you. A patient had asked, and I love this question because I often wonder myself when I get up in the morning, my bones are creaking and popping. How do you know the difference between this patient's talking about fatigue? How does a patient discern, well, this is fatigue from my cancer or my treatment versus just normal aging, or whether it's fatigue or bruising or any side effect?
Yeah, fatigue is a really tough issue. I had a attending physician when I was in my training that said, treating fatigue makes me fatigued. But it's hard, if it's really the only problem that a CLL patient is having, it can be, all those other problems I had mentioned earlier, the low red cells, the low platelets, the painful nodes, the night sweats. I with close to 100% certainty know I can fix those with treatment. Fatigue, I'm not as confident when that's the only issue that a patient's having. I try to differentiate between fatigue from other causes and old age, and specifically to CLL they try to put it as a metric, and say, if you're having to spend half the day or more just lying around, and you're not able to kind of do your normal activities of daily living, like that's a severe level of fatigue, and treatment should be considered. And I'm looking for somewhat of a precipitous decline, not necessarily just kind of the gradual fatigue that you might more relate to aging. The problem with treating fatigue is if you look at the possible side effects of all of these medicines I talked about, fatigue will be a potential side effect. So you're sometimes trading one problem and giving another, or maybe the fatigue does get better, but then the patient has some different side effect that's even worse than the fatigue. So it's hard to really help when fatigue's the only issue. But certainly I have helped some patients with fatigue. We don't have a test that we can do to know for sure, is the fatigue coming from the cancer or is it coming from something else?
That wraps up our program for today. Thank you so much to Dr. Jacobs for joining us. We appreciate your expertise and time. I am Lisa Hatfield from Patient Empowerment Network. Thank you.